I would like to thank MB Agarwal sir and INTAS for giving me this opportunity. My topic for today is management of ITP in pregnancy. So I hope my slides are visible.
Yes.
So definition of thrombocytopenia in pregnancy is the same as that in the non-pregnant state. We take a platelet count which is below the lower limit of normal, which we take as less than 1.5 lakhs per cubic millimeters, as the definition of thrombocytopenia in pregnancy also. If we take this definition, 7 to 10% of all pregnant ladies would be suffering from thrombocytopenia. But we have to remember here that normal pregnancy is associated with a decline in platelet counts. And this is because of hemodilution, which happens during pregnancy as the blood volume increases, and because of pooling in the splenic and placental circulation, resulting in sequestration of the platelets. So normal pregnancy is associated with a decline in platelet counts. And this is what results in something called gestational thrombocytopenia, which is the most common cause of thrombocytopenia in pregnancy. It attributes to around 70 to 80% patients of thrombocytopenia are in fact attributed to this condition. Why this is important is because it's a very harmless condition which will not normally cause any problem to the mother and the baby. So these patients, we should not unnecessarily subject them to treatment. So any uncomplicated pregnancy with borderline isolated thrombocytopenia is normally gestational thrombocytopenia. Dr. Das sir has very nicely listed the causes of pregnancy associated thrombocytopenia. So for classification purpose, we divide them into two groups: isolated thrombocytopenias and thrombocytopenias associated with systemic disorders. Now, isolated includes gestational, which we have discussed. It includes ITP, which is the immune-related thrombocytopenias. It can be drug-related, it can be inherited, or it can be because of PWD, type 1B. Systemic disorders associated thrombocytopenias are the most serious ones, and that's a separate topic by itself. But it is very important to keep these in mind, and especially when a patient who is not very well, who has other problems apart from thrombocytopenia, these conditions should be ruled out, because delay in diagnosis can cost the pregnant lady her life. Now, when we look at the relative incidences of thrombocytopenias in pregnancy, maximum is gestational. ITP attributes is attributed in 1 to 5% of the cases with thrombocytopenia. Now, approach to thrombocytopenia, again, I will not go into details here, but whenever we have this patient, we have to rule out all the other causes of thrombocytopenia. Only then can you say that this patient is suffering from ITP, because ITP is a diagnosis of exclusion. Gestational thrombocytopenia versus ITP, when we see, gestational is always mild. The platelet count normally never falls below 80,000, though rarely it can go to 50,000. It normally appears first in the late second trimester and third trimester. And the baby here, importantly, is not affected because of the thrombocytopenia. ITP, on the other hand, can be pre-existing to the pregnancy, or it can develop later in the pregnancy. Mostly, we pick it up in the first trimester itself. And very important to remember here is the platelet counts of the baby can drastically fall, and the baby can suffer from bleeding. So that is why it is important for us. Some people were of the belief that antiplatelet antibodies had a role in differentiating the two. We still have people who, clinicians who use antiplatelet antibodies, but antiplatelet antibodies have no role in differentiating between the two. They can be positive in normal pregnant ladies as well, even without any thrombocytopenia. So they are not sensitive, not specific. Coming to the topic proper, ITP in pregnancy, 1 to 5% of all cases of thrombocytopenia. Mechanism is the same as that in the non-pregnant state. Increased destruction, some amount of decreased production, and importantly, it's a diagnosis of exclusion. This is very important to us. It's Sometimes incidentally discovered, this is the case most of the times. Sometimes the patient can have symptomatic presentation, mostly with petechiae. Normally, presentation with overt bleeding is unusual in pregnancy. The patient could be a known case of ITP versus someone who has just come to be diagnosed now during pregnancy. This is important for management. Mandatory investigations whenever this patient comes to us. CBC with a peripheral smear examination is the most important test. A good quality peripheral smear examination. We have to rule out the presence of schistocytes here and also large platelets and pseudothrombocytopenia. Liver function test is something I routinely do along with a thyroid function test, anti-nuclear antibody, and viral screening for HIV, hepatitis B, and C. I do this routinely in all my pregnant patients with thrombocytopenia. Other investigations, depending on what the situation demands, we could do a direct Coombs test. I will do it if there is any evidence of hemolysis or the anemia is disproportionate to the degree of what is expected in the pregnant state. This is important to rule out Evans syndrome. And why this is important, especially in pregnancy, is 30% of patients with Evans have a lupus anticoagulant which is positive. And this is very, very important in the management of the patient, as Dr. M.B. Agarwal, sir, will be taking up this topic later. So important to do a DCT if you have suspicion, lupus anticoagulant. And sometimes you also need to do the immunoglobulin levels and the von Willebrand testing if the patient is refractory to your management and you are thinking of other causes. Now, role of bone marrow aspiration biopsy in a pregnant lady, it's a little inhuman to subject a pregnant lady to a bone marrow, apart from the fact that there can be some complications as well. So I routinely do not do it unless I have a strong doubt that it could be something else like a leukemia, or if my patient is not responding to the standard line of therapy, or if I have planned a splenectomy. When to treat. Now, there are different schools of thought here, but what I like to follow is a platelet count less than 30,000. However, the ASH recommendations say that in the first trimester, even a platelet count of 10,000 need not be treated. Only if it goes below 10,000, that is when you initiate your therapy. But I follow a target of 30,000, which is the same as that in the non-pregnant state. Any associated bleeding, and important is planned intervention or delivery. Suppose I want to do some procedure on the lady, like CVS. This is something I would really, really avoid. But if it's needed, or when I am contemplating delivery, the lady is near term, that is when I would typically treat this patient and keep a platelet more than 50,000. First line therapy in pregnancy, we have IVIG. Dose of IVIG is normally 1 gram per kg is what is given. We can go up to 2 grams per kg, 2 divided doses. Steroids oral are to be preferred over IV. IV used only in severe cases when there is no response to oral therapy. Another school of thought says that if there is no response to IVIG and steroids, or only steroids, you can combine IVIG with steroids to get a better response. Now, effect of steroids on the mother, we know. Even short-term use of steroids in the mother can cause hyperglycemia. It can precipitate preeclampsia, amongst other problems. And for the baby, it can result in preterm delivery. There is also data saying that exposure to steroids can result in congenital anomalies, most importantly, orofacial clefts. So the lesser the exposure to steroids during pregnancy, the better. This is important. Why? Because we have a tendency, the gynecologists, when they send the patients to us with a platelet count of 70,000, they panic. And to relieve their panic, sometimes we do start the patient on unnecessary treatment. So this should, as far as possible, be avoided unless it is really needed. The dose of steroids, again, there are two schools of thought. One says high dose steroids, 1 mg per kg, taper it, and then put the lady on maintenance till the platelet is more than 50,000. Then you again start tapering the dose and stop the steroids completely. Another school of thought says 20 to 30 mg per day for 10 days is sufficient, and you give it when the patient is near term. Role of rituximab avoided. because as we know, the long-term efficacy of this MAB in ITP is very low. And in addition, it causes neonatal B cell depletion. So I would avoid rituximab in pregnancy. Cyclophosphamide, MMF, Vinca, and Danazol are drugs which are category X. They are contraindicated in pregnancy because they are known to cause teratogenic effects in the fetus. TPO agonists, till recently, there was absolutely no data available to say whether romiflostim and L-Trombopag could be used in the pregnant lady. But of late, there are some isolated case reports, and I came across this article, which is actually a multi-center observational study, which was published in Blood, November 2019, where they have studied 13 patients, 1-3, who have received L-Trombopag or romiflostim, and they have found that short-term use of this, short-term is when we are just contemplating delivery and the platelet count is just not increasing. So maybe a 7-day course or a 14-day course has not been associated to cause any major side effects in the baby. So off-label, some people are using it. And we also have another study of 8 patients with romiflostim, all of whom had a rise in platelet counts and no significant adverse events as far as the baby is concerned. But again, it is not recommended. Splenectomy is something that we resort to when everything else fails. And it is the same for pregnancy. Failure of standard therapy, drug intolerance are indications for splenectomy. The timing is second trimester when the baby will not be affected by the anesthesia or the procedure, and the uterus wouldn't be so big enough to interfere with your field. Laparoscopic splenectomy is what is to be preferred, and bone marrow testing prior to splenectomy has to be done to confirm that you're dealing with ITP. Now, azathioprine, there is, though it does cause some immune and hematological impairment in the fetus, but it has been found safe in renal transplant pregnant patients. So extrapolating that data to hematological patients, we do use azathioprine, but never in the first trimester. Starting late second and third trimester, this is one drug which is category D, but which is still used sometimes to tide over the crisis. Now, when we look at the FDA pregnancy categories, there is category A, which is all drugs which are absolutely safe, B, which is mostly safe, C, which is they can have some adverse effects in the fetus, D, again, the benefit is slightly more than the risk, and category X is the group of drugs which are teratogenic. So, category A and B, yes. Category X is absolute no. Category D also is mostly no. Category C are drugs that I would avoid. This is the classification of drugs. Now, anti-D is one drug that I did not mention because I would personally not use it because it causes hemolysis. But there are isolated case reports that anti-D is safe in most of the pregnancies. So again, first line, what is recommended everywhere is steroids with or without IVIG. And splenectomy, again, azathioprine. The other drugs I would really use with caution or avoid if possible. Now, ASH and the British committee have a different set of guidelines as far as management of pregnancy is concerned. But to summarize, and what I would use, I would treat any pregnant lady with a platelet count of less than 30,000, irrespective of the trimester. If in the first trimester, the lady is not responding and her platelet count is between 10 to 30, I would maybe keep her under observation. It is towards term, that is towards around 34 weeks, that I would maybe, make my treatment more aggressive. The target platelet count here is more than 50,000, irrespective of the mode of delivery. It is only when you are planning for a spinal or epidural, that is when you need a target platelet count of 80,000. How often do I monitor? It is monthly or once in 2 months if the platelet counts are stable. But towards 24 weeks, I will make it once in 2 weeks, and then I will make it weekly. Now, mode of delivery again, the presence or absence of ITP itself and the extent of the thrombocytopenia are not indications for LSCS or cesarean section. We have to solely rely on the obstetric indication, whether we will go ahead with a vaginal delivery or a cesarean section. The target platelet count is 50,000 in either case. If we are using a spinal or epidural, again, it is 80,000. Management of the neonate is very, very, very important in ITP because neonatal thrombocytopenia is common. It is seen in 5 to 10% of pregnant patients with thrombocytopenia or ITP. And the risk of intraventricular hemorrhage is real. It is 0.5 to 1.5%. And the child can either die because of this IVH or can have permanent neurological impairment. This is the incidence. If the baby's platelet count is less than 50,000, 10% of neonates fall in this category, and 5% of neonates would have a platelet count less than 20,000. How can we avoid bleeding? Answer is simple. Avoid interventions which can cause bleeding, like avoid forceps, vacuum, any fetal scalp blood sampling or electrodes, and percutaneous umbilical cord sampling again should be avoided. Now, what are the predictors of neonatal thrombocytopenia? Is it the maternal platelet count? Is it the response of the mother to therapy? Is it the drugs that the lady has received? Is it the antiplatelet antibody titers? The answer is no. Just one thing can predict whether your baby will be having neonatal thrombocytopenia, and that is the outcome of the previous pregnancy. The previous baby's platelet count is the only predictor whether this baby would be in for any complications. Anything else, even a mother who is in remission, who has a platelet count of 2 lakh, can still have a baby with neonatal thrombocytopenia. So the answer to this is simple. You have to monitor the baby at birth. We do the platelet count. We repeat it on day 3. If low, daily repeat till day 5 and 7. If day 3 platelet count again is normal, there is no need to repeat the platelet count. And any platelet count less than 50,000, the cranial USG of the fetus of the infant is very important. And again, no IM injections. Most importantly, vitamin K till you have confirmed that the platelet count has normalized. And sometimes it can take weeks for the platelet count to normalize in the baby. Treatment of neonatal thrombocytopenia, IVIG and platelet transfusion if the baby has a platelet count of less than 30,000, or if there are any other risk factors for bleeding or active bleeding. Only IVIG if the platelet count is less than 50,000. We avoid steroids because steroids, as we know, can result in neonatal sepsis. So to summarize my topic, management of ITP in pregnancy can be very complex and challenging. Diagnosis of exclusion, avoid overtreatment, steroids, IVIG, splenectomy, standard modes of care. Azathioprine can be used. No data on romiflostim and Ribolid. Mode of delivery purely based on your obstetric indications. Optimal platelet count 50,000, epidural 80,000. Neonatal thrombocytopenia can be a nightmare, so it has to be predicted and it has to be managed appropriately. Thank you very, very much. And I would like to wish all my senior colleagues a very happy Guru Purnima, and especially MD Agarwal sir, who has been tirelessly training us and teaching us throughout. Thank you very, very much.